Here that we are.
Yes, okay, the recording has started.
We are recording. Good morning, everybody. What a joy to have you here. What a joy to be here with you virtually. I'm Jen Gaudiani. My patients and their families call me Dr. G. As a reminder, we are going to record only the lecture portion of this meeting. I invite everybody to mute themselves right now. I can hear some noise, and when I hear noise, I will just pause and remind folks to mute themselves. Anyone who would not like their image to be on the recording of this lecture, please turn your videos off. And if you don't wish for your names potentially to appear, just click on the area that allows you, if you hover over your screen and you click on the little three dots, you can change your name to one initial, for instance. I am actually a Bay Area girl myself. I grew up in Portola Valley. I went to Menlo School, and so I'm really delighted to be joining my friends in California this morning. We're going to talk about the medical consequences of eating disorders, and this is going to be a jam-packed, hopefully very high-yield, whirlwind hour, very full hour of information, might be an hour and 5, and then I am going to be really open to answering questions. What I'll ask you now, and I'll ask you to consider also when questions begin, although they won't be live, they will be moderated through, is please don't use any numbers when you're asking questions. We don't want weights, amount of weight loss, BMI, etc. That can be triggering for some. Thank you. So we're going to set the tone that we as parents must locate the problem of fat shame in society as opposed to the individual person's body, and provide individuals with tools to identify and resist fat stigma and oppression, rather than provide them with tools to reshape their bodies. Now, what most of us were taught, whether you're a doctor like me or a medical provider of any kind, or whether you are a parent, an individual, is that thinner people are healthier than fatter people. I use the word fat as a descriptor without any connotation of pathology. So I do not use words like obese or overweight. That weight is a product of individual choice and self-restraint. It's all about calories in and calories out. And that if people could just stop overdoing it, they'd be thinner, healthier, and happier. These are some of the underpinnings of how we think about food and weight in our society. Now, thin privilege is a really powerful force. And a great quotation is, thin privilege is never having your body shape used as a shorthand in books, comic books, and movies for gluttony, greed, or villainy. Plus, I am aware as a person with thin privilege that bodies like mine move through the world more easily and more safely. Thank you. Almost in every facet of society. And thin privilege, the reason I begin with this, helps cause and sustain eating disorders. We are bombarded from an early age. You look at these images of Disney villains, and you see that the buffoon and the evil person is fat, and that the pure, good, moral hero is slender to the point of ridiculousness that doesn't exist in the world. But children are taught then to see body shapes and make judgments about who that person's character is, because that's what we're taught to do. How does this show up in parenting? Well, it's everywhere. Of course, all of us want to help raise healthy, well children. And we then think about, how do I make sure that I have the organic apples? And how do I make sure that we resist quote unquote junk food so that my kid knows the difference? How do we emphasize exercise? How do we think about weight with our kids and want them to be in a healthy range as society dictates that? And how do we talk about our own bodies as a result? I can't tell you how many friends of mine I've heard around April, probably earlier in the Bay Area, start to say, oh, I don't want to get into a swimsuit. It's getting towards bathing suit season. I don't really want to get in the pool. So parents do not cause eating disorders. And fortunately, we all have the opportunity to continue to show up in optimal ways in the way we think about these topics and the way we share them with our kids of all ages. I want to emphasize that you cannot tell whether someone is healthy by the appearance of their body, except perhaps at the far end of the spectrum. And that we need to remember that praises for quote unquote healthy choices may inadvertently be praise for a fledgling eating disorder. Let's talk about the biology of deprivation. So I love talking about what I call the cave person brain. And that acknowledges that human beings evolved to survive starvation. Over millennia, our brain became exquisitely beautiful at saving us from inadequate calories. And when I say starvation or malnutrition here, I'm not talking only about the bodies that end up underweight. I'm talking about insufficient energy intake for any reason compared with what a given body needs, regardless of body shape or size. What's so brilliant about the way that our beautiful brain works is that it's very different from the way that I was taught as a physician, and many of you have been taught. So the way we were taught was that there's a fixed metabolism. Our body needs the same amount of calories every day, that if we undereat or work out more, we'll lose weight, or that if we quote unquote overeat or we work out less, we will gain weight. This is false. This is scientifically untrue. Our metabolism is highly dynamic. So let's say that a given person who is well rested, well nourished, and not too stressed needs about this many calories a day for their body to run happily. If for any reason they eat less, their cave person brain senses it and says, no problem, I'll reduce how many calories you need, and their weight will stay stable. And then if the person eats fewer, once again, their metabolism will drop. Now, it's possible that in some cases, the person may undereat their metabolic needs to a degree, which when combined with a certain genetic predisposition will result in weight loss and underweight. In many people, however, this kind of restrictive pattern actually promotes weight gain because our bodies are designed to spare us from the ravages of starvation. On the positive side, as somebody who fears eating very few calories and noticing that their weight is either not falling anymore or is rising, they think, because of society, I can't possibly eat more or I'll gain. Untrue. As they eat more, their metabolism speeds up. And as they eat more, their metabolism speeds up. So ultimately, someone can out-eat fundamentally what their body needs for that day, and that can be stored and result in weight gain. But our metabolisms are highly dynamic. You cannot break your metabolism. And how does our cave person brain change our metabolism? Well, it does so in a myriad ways, which forms the basis of what I do as an internal medicine physician who specializes in eating disorders. Among the options for what any given person's cave person brain might do is, for instance, to create cooler body temperatures, including hands and feet, so that the body isn't responsible for keeping the 98.6 degree temp. Rather, we seek sweaters and warm cups of tea. We might have a slowed heart rate, slowed digestion. Eventually, sex hormones revert to pre-pubertal levels, which contributes to fragile bones and injuries. And then our brain changes. A starved mammalian brain does not lead to creativity, joy, and spontaneity. It gets very focused and serious and rule-bound because that's more likely to result in finding food. That also uses fewer calories. Then at the same time, the effects of undernourishment on the brain lead to a drive for food. That's how our ancestors survived. They try to preserve our weight at all possible costs and to say, hey, when we have any food at all available, let's try to raise that set point weight so that we have more resources the next time we end up in the desert. What's so important to remember is that every single eating disorder diagnosis comes with caloric restriction, regardless of what else happens. And weight may or may not change with eating disorder behaviors, which is not, varying around sort of, am I good enough at my eating disorder, but rather, what are my genetics? Just what do my genetics dictate will happen when I go through these behaviors? in the final analysis, it is possible that long-term engagement in dieting, restriction, et cetera, which is all the same as far as our cave person brain is concerned, can lead to a genetic set point weight change. That is where our body sort of likes to generally be within a certain range because it's trying to save our lives. So what is actually healthy eating? I personally believe that 97+% of the American populace engages in disordered eating because of the pressures of thin privilege and the mistakes of Western medicine in describing people what happens between food and their bodies. Healthy eating, I would say, is abundant, satisfying, balanced, regular eating without set rules or restrictions apart from honoring allergies, and moving your body for fun and to achieve athletic or personal adventure goals, but not as a compensation for food consumption. By the way, if we didn't mention it, I will be happily giving out a PDF of these slides afterwards. Anything else apart from this is disordered, even if it doesn't rise to a formal eating disorder. And so here again, we see this dynamic metabolism. We're talking about the flow of as we eat less, we spare more calories. As we eat more, we burn more. The science of normal adolescence is really important. And it reminds us that just like none of you, I can assure you is not me either, no child springs from their child's body into a fully formed, perfectly prepared adult's body without going through some awkward changes there in the middle. Adolescence involves a remarkable, miraculous process of turning a child into an adult. And that always comes with meaningful weight gain. And not all of it looks like it belongs on the cover of Teen magazine. That is fine and normal and wonderful. In fact, almost all children specifically thicken up around their middles as their bodies go through their years of adolescence, because tummy fat is Mother Nature's checking account. It's what's usable right away to be able to do the amazing work of adolescence and growing up. However, in our highly conscious body world, children and parents alike can feel very unnerved by a complete shift in a body set that they were accustomed to. And pediatricians, unfortunately, can play into this. Normal adolescence comes with major weight changes. Be peaceful, be supportive, watch your child's relationship with food, movement, and emotions, not the appearance of their body. Because, oh my gosh, there is a lot of body pressure in adolescence. All of the teenage roles in all of the shows that kids watch are played by 25-year-olds. There are no teenagers who look like these people. I mean, and if there are, they are absolutely super rare. And yet this is what our kids watch. This is what their parents watch and think, is this what it's supposed to look like? Even when they know cognitively, surely this isn't what it's supposed to look like. There's the question. And the reality is that when teenagers are routinely being played by 25 to 30-year-olds, all of whom have personal trainers and chefs, and by the way, enormously unhealthy body challenges themselves, they're going to have appearances that do not resemble what our kids look like, and we have to make sure that we leave space to have that discussion. Because when we focus on dieting or on body change, we invariably worsen health. Dieting among adolescents leads to greater weight gain, and body dissatisfaction is the #1 predictor of early onset eating disorders. Plus, weight cycling is deadly. That means gaining and losing weight over and over. This is invariably what happens when people try to lose weight. And I would say that the diet industry says, oh, well, you failed because you didn't do it right. If you buy our new points-based system, you'll finally take the weight off and keep it off. Are there a very, very, very tiny percentage of people who aim to lose weight and then live that in a healthy way? There are. But the vast majority of us have cave person brains that will not allow deliberate weight loss through restriction because we are biologically programmed to resist that. And as a result, people lose and then gain a little more, and then lose, and then gain a little bit more. And in an important study, those with the highest quintile of lifetime weight cycling compared with those who had the least weight fluctuation had almost 100% increased risk of cardiovascular disaster, including death, heart attack, stroke. We really have to think about this when people say, I'm losing weight for my health, and we understand that focusing on weight loss as a primary outcome is biologically programmed not to succeed. We got to take it back. And then we say, well, if this doesn't work, why is this a multi-hundred-billion-dollar industry? Why is everybody doing this? Because if I told you you're going to get on an airplane, you have a 97% chance of crashing, do you want to really board? You would always say no to the airplane, but why is society continuing to say yes to a focus on weight loss? And it is because of the power that has been ascribed to thin privilege in our society. That is a systemic harm, but we all have the opportunity to give it less power, to talk less about other people's bodies and our own negatively or positively, to really devalue the appearance of a body as representative of a moral or health state. Because focusing on weight loss has a reasonable goal. People want to improve health, vitality, and acceptance. But the actual outcome is weight cycling, dismay, and wasted time and energy. So for health, focus on staying active within one's ability and being able to regulate emotionally, not on body shape or size. Let's talk about some of the complications of restriction. Emily is a 16-year-old Caucasian cisgender cross-country runner and straight-A high school student. For the last 6 months, she's gone on a health food kick. She loses weight and everyone compliments her for eating clean and for how good she looks. She gets full and bloated quickly now, which her burgeoning eating disorder voice says this food is bad for you. She's getting constipation, nausea, and distension, which make eating even harder. She trends from healthy choices, so-called, into rigid food rules, and as her brain gets more starved, she develops body distortions. Her parents initially feel good about their child's refusal to eat junk food, but they start to worry as they see her eat less and lose more, and they bring her to the pediatrician. In a non-eating disorder informed setting, and I really want to validate all of you who have had harmful experiences at the hands of the medical system, the nurse on the way in tells her she looks great. The doctor sees a heart rate of 45 and believes her when she says it's because she's a runner. Her lab work is normal. He tells her to just keep eating healthy foods, and she's not that underweight. She continues to restrict for 6 more weeks, insisting she's fine before she passes out and is admitted to a hospital and then an eating disorder program. Let's roll it back here. Let's imagine that the same malnutrition happens, but a different narrative occurs. Let's say that this same Emily has always had texture issues. She was a very picky eater as a kid. Maybe she's always had digestive issues that worsen with food, or she's anxious and she developed emetophobia or fear of vomiting that led to malnutrition, never got a drive for thinness or body distortions. We're going to diagnose her instead of with anorexia with ARFID. Let's imagine in a different world that Emily just happened to become medically malnourished while eating clean, never developed fear of food or drive for thinness, was just sort of going along with whatever her running team coach was saying. Then we might call that relative energy deficiency of sport or REDS. But regardless of diagnosis, this is when eating disorders often begin. Here's a really nice chart of REDS. This comes out of a terrific paper that identifies in the middle that red triangle shows what used to be called the female athlete triad. Clearly, that was way limited because now we understand that every possible organ system and every gender is affected by inadequate nutrition relative to what a body is needing to do each day. So Emily's harm was internalized size bias on the part of everyone around her and her pediatrician. Because she looked like a stereotypical successful 16-year-old, he missed key signs and enabled her eating disorder. And her brain was starved way longer than it should have been. Things that we can look for as families and parents on exams, well, lanugo hair can grow on people's cheeks again as they become malnourished, more typically associated with underweight anorexia, but can be seen across any sort of malnutrition. This is the body reforming fetal hair to keep the head warm. We said that when someone is starved, they drop their metabolism, so they're not putting as much energy into keeping themselves warm. Yes, the body grows fur to keep the head warm. That, even when all the labs are normal, is a very important sign of malnutrition and things not being okay. And it's a sign of slow metabolism. Most of our kids do not want to be told, hey, you know what your restriction is causing is a really, really slow metabolism. Then also people get chilly. So this is a particularly vivid example of what's called acrocyanosis, or blue pertaining to the ends from Greek. And our blood flow is decreased to our limbs, whether or not people end up with the bluish appearance. Their hands and arms and feet and ankles may get chilly because the body doesn't want to spend energy on warming those. It's being calorie conservative. What about this starved heart business? What about this low heart rate? Is it an athletic heart? Is it a starved heart? Well, hibernation happens sort of biologically when people starve, and it's mediated through high vagal tone. Vagal tone is one of the sort of major modes that our body can enter into. This results in a slow heart at rest because people don't want to spend an extra calorie on an extra beat of the heart, with blood pressure relatively unchanged when people stand up and sit down. Here's the key though. A really well-trained athlete who is nourished, rested, and hydrated may have a slower heart rate at rest. Even Olympic athletes do not often have heart rates under 50. And when they walk across the room, that's nothing for their hearts. That's no problem because they have muscles that are well-nourished, well-rested, and well-hydrated. However, a starved person's heart will start beating like a hummingbird's. It might increase by 75%. It might double or triple. That is what a starved person's heart looks like. And so I have practitioners do what's called the walk across the room test. Walk down the hall and back, recheck the pulse. Roughly speaking, this is not a validated measure. If it increases by 75%, that's something that can help you. Now, do some people's heart rates not change? Yes, this is not in everybody, but it's something to watch for. And P.S., as a reminder, while hibernating, bears don't do all of these things that take energy and time and effort. They sleep. So let's talk about Emily's digestive stuff. This is going to be a good long section because I know this group was interested in this. Gastroparesis refers to the loss of normal stomach wriggle that moves food south. It is nearly universal in weight loss. It is nearly universal in restriction, even when it doesn't cause weight loss. This is regardless of body size. And it causes that early fullness, like I feel Thanksgiving full after eating half a sandwich, nausea, bloating, and gassiness. It's so quintessential to the relationship with restriction that you almost never need a formal gastric emptying study. Although when things get murkier and you're not sure, those can be very helpful. What worsens gastroparesis is high fiber diets. And ooh, what is safer to people with an eating disorder than those clean vegetables? Rapid weight loss or a long time underweight and severe restriction all worsen gastroparesis. What helps is smaller meals, liquids and semi-solids, frequent meals, low fiber and calorie dense. So what I'll often say to patients when they're sort of in that like, Dr. G, I can't increase my meal plan because I'm way too full. I will say, in addition to offering medications, you have two choices. You can be physically uncomfortable and emotionally safer by eating large volumes of safe foods, or you can be emotionally uncomfortable and physically more comfortable by eating very dense foods. Either way, you are doing this calorie increase. You get to decide which pathway you're going to take. But to be clear, you are not too full to do this calorie increase. We can put a couple pats of butter in your oatmeal and a couple more spoons of brown sugar. This will not take up any more room in your stomach. So prescription options, I say these so that you're familiar with them, not because you'll necessarily be prescribing them. In my patients, my first line med in kids, teens, and those who are sensitive or have a history of bad reaction to meds is cyproheptadine. It's an old-fashioned antihistamine, and you give it, it comes in 4 milligram tablets. You give half to 1 tablet at bedtime. It does 3 lovely things. 1, well, it's only taken once a day, which is easiest. 2, it helps motility throughout the whole GI tract. Then it also helps people go to sleep, and starved brains do not go to sleep easily. In fact, some of my patients say the thing that will keep me from relapsing is that I value my good sleep so much. I never want to feel like I used to do when I was undereating. And finally, cyproheptadine can stimulate appetite. I let patients know that straight off. I am not looking to break their trust by sneaking something by them. I will say, this medicine can increase your appetite. Appetite can be scary, but if you're going to need to be on a pretty solid meal plan, it can be helpful to be hungry for it. Would you like to try this medication? Other options include metoclopramide, also called Reglan, half a tablet, 30 to 45 minutes before meals and at bedtime. If that's not enough, we sometimes add erythromycin ethylsuccinate liquid, 200 milligrams twice a day, or its cousin azithromycin. I don't love those. I don't love giving anybody chronic antibiotics, and they can prolong the QT interval on the EKG and increase the risk of cardiac arrhythmias. But if you've got someone who needs to eat and their gastroparesis is bad, you got to do whatever you can to get them to tolerate the food. Now, constipation, same as gastroparesis, is nearly universal in caloric restriction, regardless of body size or weight loss. And again, our metabolism has slowed to spare calories. They don't want to spend extra calories on regular wriggles of the gut. Similar to gastroparesis, high fiber worsens constipation at low weights. It just makes people bloated. Long-term laxative abuse may slow the colon further. Good things to use are osmotic laxatives. By the way, I have no financial vested interest in absolutely anything I'm talking about today. So Miralax, Milk of Mag, all of those can be helpful. Good nutrition, a good potassium level. Glycerin suppositories, for those who could tolerate those, can help, because when you put a glycerin suppository in the rectum, it melts and it lubricates stool that's acting like a hard cork and preventing other stool from passing. But what if all this isn't enough? Let's go next to irritable bowel syndrome. IBS can come in constipation, diarrheal, or mixed subtypes. We now call these disorders of gut-brain interaction because the Western medicine geniuses have finally figured out and validated that the gut talks to the brain and vice versa. It affects 11% of the world's population, and you just need to find out what individual patient needs what care. The Rome 4 criteria are remarkably generous. Many of you will read these and be like, boy, it would be nice only to have my kid suffer these 3 days a month, but it's recurrent abdominal pain or discomfort at least 3 days a month in the last 3 months, associated with just 2 or more of the following. The symptoms improve when they poop. The onset was associated with more often or less often appearance of poop. And the onset was associated in more loose or harder appearance of the stool. I want you to recognize meds. I know how vitally important you collectively are as advocates for your children. So oftentimes I'll see patients on the wrong meds for the wrong kind of IBS. For constipation subtype in the US, we have Amitiza, Linzess, and Trulance. I generally tell patients your insurance won't cover at least one of these won't work or will have poor side effects, and one of them will be decent. That's about all we can expect out of these. For diarrheal subtype, the first line treatment is a non-absorbed medicine called a bile acid binder called Cholestipol. You take 1 gram 30 minutes before breakfast or as many times a day as needed, and it absorbs the bile that likely contributes to diarrhea in IBS diarrheal subtype. We also have a lot of other good meds, the antispasmodic Bentyl, Levbid, Lotranex. And of course, none of these are proven with concurrent malnutrition, but I regularly need to use these medicines because I'm trying to remove medical barriers to make an already challenging recovery process easier. What about when gastroparesis isn't present, the upper endoscopy is normal, but this nausea and vomiting persists? Think about what's casually called gastric IBS. We also can call it visceral hypersensitivity syndrome. Interestingly enough, an old-fashioned tricyclic antidepressant, nortriptyline, amitriptyline, low dose, once at bedtime, can be amazingly effective. I've cared for patients who were throwing up everything without wanting to or meaning to. They didn't have gastroparesis, their electrolytes were okay. Nortriptyline turned it right off. So then let's say that's not enough, because we have to talk about all the tools in our toolkit. Let's think about muscles and those with IBS plus. It turns out that the function of our diaphragm is really tied to digestive function and overall wellness. It's also tied to chronic low back pain, chronic pelvic pain, headache, TMJ dysfunction, vagus nerve inflammation, and depression and anxiety. How is this possible? Well, it turns out that every time we take a nice deep breath, so on me that goes, the diaphragm massages our guts forward and it moves the stool and the gas forward. It also stimulates our vagus nerve, which triggers our parasympathetic or relaxation responses. In a system, a person's system, that has too much muscular tension, maybe scarring, and folks who no longer are taking super deep breaths, all these healthy benefits can malfunction. The next slide is going to be an anatomic slide, a drawing, not a picture, but I want to just alert you in advance. Let's talk about the pelvic floor muscles and how they play in to constipation and digestive function. So our pelvic floor muscles are a beautiful interlaced interaction of muscles that, in those assigned female at birth, uphold the uterus, and then in everyone, the bladder and bowel. Function and sensation across all of these tissues have everything to do with the pelvic floor. So what happens when the pelvic floor malfunctions? Well, there's something called pelvic dyssynergia that Rome 4 has also described criteria for, including having to strain to pass a stool, feeling every time after you poop there's still stool left, and having difficulty relaxing to evacuate the stool. What I've noticed in my practice is patients who might need to self-disimpact by manually removing poop, those who have stool incontinence because their muscles aren't strong enough to hold diarrhea in, or those with meaningful abdominal distension often have pelvic floor dysfunction. So what can go wrong? Well, in my patient population, there are a number of things. There's chronic tension and anxiety that often sit in our core muscles, and unfortunately, a societal drive to keep the stomach held in, plus people who overexercise, may overuse their core, can lead to high tone. In other words, they're too tense to relax, so that nothing can get through easily, either gas or stool. Then we have cycles of dieting or restriction for any reason and muscle mass loss. And what you end up with is a tense, weak pelvic floor that is almost universally found in my patients with these symptoms. So how do we diagnose it? Well, you can do something relatively invasive with a balloon and an expert called anorectal manometry, but you don't really need that for most cases. A skilled pelvic floor physical therapist is your best friend in this situation. They can do an amazing exam. They have such remarkable skills. Now, patients who have experienced sexual trauma, or who are young, or who are extremely modest, this is a very intimate and invasive experience, and that may not be right for them. However, for those who can tolerate it, physical therapy and biofeedback are unbelievably effective in reducing pelvic pain, pain with penetrative intercourse, urinary incontinence, constipation, diarrhea, stool intolerance, etc. But what about those who can't receive that for any reason? Well, it turns out that abdominal wall dysfunction is just as important as pelvic floor dysfunction. And just as in the pelvic floor, the abdominal wall can become very, very tense. I describe it as an internal corset. It wraps around patients' intestines and stomach and causes early fullness, nausea. It is the determinant of nausea with anxiety. That's the kid who gets a tummy ache or gets nauseated or throws up before a test or before a big game. That's the patient who every time they get anxious, they feel instantly nauseated. That's what's causing it. So a great PT can gently massage the abdomen and release these myofascial tensions and be unbelievably relieving. They can teach patients how to take those deep breaths again when the diaphragm is no longer pushing against a system that's so tense. And then diaphragmatic breathing can really help with reflux and with rumination. And there's no intimate work. So this really is like an amazing, amazing tool. I also just want to think about these kids, typically it's kids, but it can happen in folks of any age, who have that highly sensitive stomach and they're prone to nausea. Oftentimes that can be the cause that leads into anorexia or ARFID. I cannot tell you how many young ones I've been able to send to abdominal wall PT and knock out that cycle, because then their tummies aren't so tight. They can breathe, they can bring on that vagal tone, they can ease the symptoms, and they no longer feel nauseated, which can lead to fear of nausea. So this is an amazing primary prevention. Let's talk at least briefly about small intestinal bacterial overgrowth. Our small intestines are supposed to be sterile, even as our gut, our colon, is supposed to be full of rich, wonderful bacteria that really mediates our health status. Anyone who has reduced GI motility allows bacteria to crawl from the colon and colonize the small intestine. Then it begins processing food too early. It reduces a huge amount of gas and inflammatory markers, and it causes a ton of symptoms. People with IBS, at least 50% of them end up with SIBO at some time, and it's very easy for SIBO to recur. What do we know that causes loss of GI motility? Any restrictive eating. So the manifestations of SIBO range from really, really bad malabsorption looking like celiac disease to mild symptoms that just sort of look like IBS. There is lactose breath testing. The way to do that is found in my book, but it requires dietary restriction that I feel is usually not appropriate for my patients because I don't want to have them get off of their routine of eating. But SIBO can increase sort of the cellular permeability and translocate endotoxins. It can cause people to feel profoundly fatigued. It can cause skin changes. It can really, really cause a lot besides tummy problems. This talk is not long enough to go into all of the treatments, but there's a lot of interesting treatments out there. My exciting learning curve is to get as much functional medicine information as I possibly can. Boy, have I been humbled in the amount that my Western medical training at Harvard, BU, and Yale did not teach me. So while prescription rifaximin remains one of the classic go-tos, increasingly really brilliant functional GI dietitians have been teaching me about a variety of other products that can help naturally get rid of the bad bacteria, help with forward function, and of course nothing helps that more than consistent, adequate eating, helps protect against some of the inflammation, helps feed the good bacteria, and then helps sustain a good bacterial milieu. Especially we're thinking now that the spore-based probiotics are the best ones to use and they're most tolerated by the majority of people. This is really exciting. It makes a big difference. And I want to acknowledge as well that when we get into the herbal side, things can get expensive very quickly. Let's briefly mention so-called atypical anorexia nervosa. Atypical, as most of you will know, means the person has all of the symptoms and behaviors of someone with anorexia, but they don't live in an emaciated body. Now, The data, the literature would suggest that atypical anorexia may be present in 3% of the population. I think it's way higher, way higher. This is radically underdiagnosed versus, remember, 0.1% with anorexia. So which one is atypical? Here's where we come back to the fact that our cave person brain makes it most likely that even when restricting without binging, a person is more biologically likely to gain weight than to become underweight. I've come to believe that it's probably sort of an accident of genetics for those who actually end up underweight when they restrict. Atypical still comes with double a death risk compared with age-matched peers. And I'm a big fantasy fiction nerd, so it takes patients as diverse as this, and it only identifies the ones that look like this. Why do we even say atypical? This is weight stigma in the DSM-5. For instance, we don't identify and separate out atypical binge eating disorder versus binge eating disorder based on those who gain weight when they binge. We don't have a cutoff for atypical self-harm, atypical substance use disorder based on some arbitrary outcome. This is about the way that research physicians in particular, but the medical field overall, continues to focus more and more compassionately on those who become underweight in the course of an eating disorder. All the medical complications seen in anorexia are seen with equal frequency and severity in atypical anorexia, except maybe bone density loss and hypoglycemia. All the rest, psychological batteries and the medical batteries, are the same between these two groups. And we know that in adolescents with restrictive eating disorders, total weight loss and recent weight loss are better predictors than admission weight of medical complications. Now, parents will have gotten unbelievably gaslit by their medical providers with this. The medical providers who say, well, your kid was always a 90th percentile kid, now they're a 60th percentile kid. You know, maybe they're just thinning out, maybe it's okay. And the parent's like, I know there's something wrong. Believe yourself, trust your spidey sense. Let's do some cases. Jack is an 11-year-old boy. He's always been at the 80th percentile weight, 50th percentile height, which is congruent with family body type. Over the last year, he has been hungry all the time and his weight surged, and he started expressing self-consciousness about his body, especially his tummy. His mom expresses concern to the pediatrician at his well visit, and the pediatrician acknowledges he is now at the 90th percentile weight and kindly says, hey, let's watch the sugar a little bit, let's watch the junk food and the juice, and talks openly with Jack and his mom about the future medical risks related to high weight. Jack is determined. He cuts out sugar for Lent and starts to lose weight. People praise him. His list of off-limits foods grows rapidly, and he starts counting calories and exercising every day. After 4 months, his weight has fallen lower than it was at his 9-year-old well visit, even though he's still not formally underweight. His grandparents and uncles tell him he's looking fantastic. Hey, kid, you really got yourself together this time. He's now at the 40th percentile on the growth chart when his mom brings him back in, now really worried that he won't break any of his food rules. The pediatrician now diagnoses atypical anorexia and refers him to a great dietitian who works with him on good fueling. Then suddenly overnight, Jack starts binging on all the sweets in the house, and his weight rises rapidly over 2 weeks. He feels out of control and ashamed and says to his mom, I knew it. I am addicted to sugar. Okay, let's talk about restricting to binging. This is biological. It is not a loss of control that is mediated by anything we can control. I like to tell my patients and their families, let's imagine that your ancestor and mine were walking 1,000 years ago through the rocky tundra, and they hadn't had enough to eat for a couple of days. They get to the edge of a forest and they find a beehive. What they did not do, and this is proof because we're sitting here today, is dip their finger in the beehive and go, oh, that was tasty, let's move on. They knocked that down and they devoured it. They scoured every molecule of honey from it, not because they have a sugar addiction, but because they didn't have enough, and our brains are programmed to get in what we need when we have access to it. So this is why consistent non-scarcity eating is best. All foods can be part of a daily intake. We just think about general balance and general moderation. So Jack is at risk of diagnosis switching to binge eating disorder. It's not super common, but it absolutely happens. And binging can happen without the diagnosis of binge eating disorder. What's key to remember is rebellion and restriction are typically what drive binging. So there is no such thing as sugar addiction. That's a flat earther situation. I'm going to speak real frankly about that. And everyone needs carbs. 50% of our energy should come from carbs. In fact, people who follow keto diets, short of needing to do so for epilepsy, for instance, actually fail to nourish the bacteria in our colon. We now know that keto diets after 1 month lead to bacterial die-off because our bacteria aren't getting enough nutrition. And as a result, people can end up with SIBO, with bloating, and with a lot of other inflammatory conditions. Let's think again, we talked about sort of normal puberty. Let's think about puberty and weight. So many studies show that dieting leads to greater weight gain. And so with regards to Jack, at the original 11-year-old visit, let's roll back time and imagine that the pediatrician, instead of jumping straight to watch your sweet, says, let me just ask you some open-ended questions. How are you feeling about your hunger these days? How are you feeling about your body? Yeah, man, there's so many pressures on boys right now to look a certain way, but bodies come in all shapes and sizes. And the best thing we can do is really embrace that and dress well and remember all of the ways in which you show up in the world that have nothing to do with your body that are absolutely amazing. We ask him about his relationship with food and movement and what he's hearing. Doctors carry remarkable power either to reinforce weight stigma or to apply a scientific lens to healing it. The doctor can show him his growth curve and say, adolescence is totally the time for major gains in height and weight, and gaining in your tummy is really normal. Your body's doing amazing things. If in those questions, we learn that Jack has been using food to self-soothe or for other reasons than satisfying hunger, or maybe food insecurity is present. The Cape person brain doesn't know whether inadequate food comes from food insecurity, a diet, or an eating disorder. Or maybe there's big emotional upheaval in the family. This is a great time to refer him for support and reassure him that eating enough throughout the day is best for his body, never dieting or denying himself some of what he wants. This is a great time for psychoeducation for Jack and his mom, that it's a risky time for disordered eating to start, and that his weight and body will be healthiest with no lifetime dieting, and to pay more attention to behavioral habits than body shape and size. Valentina is a 10-year-old girl who began puberty early. She's always been 60th percentile for weight on the growth curve. Her pediatrician sees her weight has risen quite a lot over the last year and warns her and her mother to make significant changes. It's a big family history of diabetes, so they're worried. And within 6 months, Valentina's lost a bunch of weight and is fearing food and weight gain, even though she's not formally underweight. She's tired, she can't concentrate, constipated, feels cold, very anxious, and has developed a bunch of OCD behaviors, and she stopped growing taller. Pediatricians recognizes these are from atypical anorexia, refers her out, but then everyone, parents, kid, team, are wondering, what should her target weight be? Does she have to return to the 95th percentile she was before she started losing weight? Do we need to go back to the 60th percentile before puberty? So Google this, it is amazing, Eva Musby growth chart, and watch the 8-minute video. It is incredible. For the most part, we want to get kids back to their most usual percentile on the growth curve. We don't want to under-restore them because medical and psychological issues can persist or become chronic. We have to recognize our tendency for internalized size bias. And it's not that we're making things up. May our kid, who's been fatter her whole life and been bullied for it, have an easier time socially when she's thinner. And so our heart aches knowing that she's got to get back, at least for now, to the body size she was. Yeah, that's really hard. If the parent is struggling with that, do your own therapy around it so that you can show up for your kid and say, I love you so much. Those kids are such jerks. This is where your body is healthy, my love. Another great blog to check out, if you Google Emily Boring, B-O-R-I-N-G, what I wish I'd known, this blog will come up. It's a great blog by a young woman who describes that her pediatrician set her minimum safe weight early in her anorexia when she was 17 or 18 at a certain weight. She doesn't use any numbers in the blog. She calls that BMI X. And of course, her anorexia said, I can never be above BMI X. That's the minimum, that's the maximum. And what she found was that even at BMI X, her brain didn't function right. Her relationship with her body and food was still disordered. What she learned over time was that BMI X plus 2 led her to be a whole human again. So these months of recovery are super hard for the parents who are overseeing every meal. They can't believe she needs to eat 3,000 calories a day plus to gain a pound or 2 a week. But almost like magic, when she happens to hit the 70th percentile, her parents are like, oh, my kid is back. She's happy, creative, relaxed, and her body distortions improve. Camilla is a 17-year-old with atypical anorexia who's been receiving good treatment and is doing well. She's been a soccer player since she's been little, and it's a part of her identity. But overexercise has also played a big role in her eating disorder. She'd like to get back to soccer in recovery, and her team wonders, when is this safe? I used to do this wrong. I used to say, recovery is a privilege, exercise is a privilege of full recovery. I was wrong. As with so many things, outpatient practice has made me very humble. Now I understand that movement, with certain exceptions, makes recovery sustainable. Telling patients don't move, you'll burn calories only reinforces the eating disorder belief about the role of exercise. This is an amazing article you can share with anyone who will listen. All of us were told exercise is for burning calories. That dumbass Stairmaster that I spent time on as a teenager that was so unhealthy. Nope, it's not about fixed metabolism, burn calories below it. Indeed, a great study was done on a modern nomadic people called the Hadza. And they very exquisitely were able to monitor exactly how much fuel these individuals needed who walk 10 miles a day, let's say. And of course, the Western scientists who performed this study said, we're going to show those American couch potatoes. We're going to show them how much more fuel these active movers need than people who are holding still. And then to their shock, they found it was identical. They needed the exact amount of fuel. They burned the same number of calories a day as the American quote unquote couch potato. They said, how can this possibly be? But what you know now is that the cave person brain is biologically designed to be calorie conservative. So while these individuals are using energy to walk all day long, their body brilliantly downregulates their metabolism elsewhere so that their gut gets fewer calories and their heart gets fewer calories and their hormones and their brain so that they conserve fuel. So when our kids want to go move and be athletic, it's not about burning calories. It's about giving them extra fuel so that their cave person brain isn't reducing fuel elsewhere. This is why relative energy deficiency of sport happens. This is why periods disappear. Because even as the kid may be stable in weight and doing their sport, you'll see that periods go away because the cave person brain says, no. Not a safe time to have sex drive, have period blood loss, have sex, or get pregnant. Nope, shut it down. So when we're encouraging our kids with movement, movement is for joy and vitality. It's for strength. It's for future cardiovascular health. It is not for burning calories, but we need to fuel the body when we move it so that it doesn't steal from other systems. So as soon as Camilla proves she can fuel consistently as recommended by her dietitian and overseen by parents, if she's gaining weight, if that's part of her plan, and she has improvement in her vital signs, we have options. I get people back to movement so fast. It could be that one team member, whoever feels most comfortable, takes the lead on guiding movement parameters and makes sure that we communicate, especially with the parents. We might start 1 to 2 days a week of mindful, sport-appropriate movement that builds strength and endurance. Maybe it's a 5-minute walk, 5-minute run, then processing in a journal. Did I dissociate? Was I focused on numbers? Nobody should wear Fitbits. Nobody should be counting anything. Everyone should throw away their monitoring devices. They are useless. They put the locus of authority external to us, and somebody says, you've done enough. You've done a good job. We're teaching our kids. The locus of authority must be from within. Have I done enough today? Am I more tired today? Do I need to slow it down? Do I need to do less? Do I feel super pumped and energized? And do I want to do more today? The locus of authority must be from within. We want to vary movement, keep following her medically with accountability, advance her permissions as she wants and is able, or maybe the coach oversees this and the coach keeps the team in a loop. I've had many treatment teams that include a coach, and I've had the pleasure of bringing individuals back to middle school, varsity, pro, and Olympic level sports. We want to identify that re-embracing athletic identity are all better than embracing the eating disorder identity. And when a patient isn't sure what's driving what, I've learned from great pros that if somebody is driven by athletic identity, they will do whatever it takes to get better, including eat more, rest more. If they're driven by eating disorder identity, they will be driven by fear. They will not be able to rest more or eat more, even if that would improve their performance. And we know the ED is in charge. Let's talk purging physiology. Jorge is a 19-year-old Latino male college wrestler. He's been through countless seasons of dropping weight to make his weight class, from caloric restriction to laxative abuse to sweating it out. He feels worse and worse about himself each season, and he's starting out heavier this season because he grew an inch since last season, but his coach still wants him to compete in the same class. He has a scholarship. He wants to compete. He'll do whatever he has to do. And you hear guys in the locker room talking about low carb and paleo. He tries, he wants that edge, but he's just exhausted and weak at practice. He starts doing more body comparison, and he doesn't want to be thin. He wants to be muscular and lean. So because he has a cave person brain, of course he starts binging at night. And then unfortunately, he feels driven either to try to do extra exercise misguidedly or to purge by vomiting. When he then tries to stop purging, he swells up and gains weight, which reinforces his belief that, oh my gosh, I have to keep doing this stuff. His muscles feel cramped, sex drive and function decrease. And, this is a known behavior. The harm here is that males often feel unseen and underrepresented. They may not even know they have an eating disorder. And yet, mortality studies in males show that they have double the death rate of women with eating disorders, double. So the Swedish study looked at over 600 male patients who got hospital care for anorexia over almost 30 years. Those male patients with anorexia plus any other psych diagnosis had a death rate 9 times higher than healthy peers. Those who had anorexia and abused alcohol, 10 times likelier to die of natural causes and 35 times likelier to die of unnatural causes than age-matched peers. And then we have a bunch of different studies that show that in hospital settings, especially with anorexia, the men die twice as much as the women. And what is going on here? So this was the Batman and Robin of my youth, maybe yours as well. These were 2 sweet, sort of doofy dudes who were walking around saying pow. And, they certainly had thin privilege, but what is this? His abdominal muscles are so cut that he needs special cuts in his suit to protect them. What is this nonsense? This is a very different vision of what somebody who is super and magical looks like. Similarly, again, big sci-fi fantasy nerd. This was Luke and Han action figures from when I was a kid. And then in the 2000s, the action figures were re-released. Clearly, the guys did not have a sudden obsession with steroid use or an eating disorder, presumably, but their bodies look remarkably different. And that's what our kids were given. So you're like, okay, come on, Jen, this is a little much. Why are you being so pedantic about this? Well, when we put our little boys in Halloween costumes that look like this, we're telling them that their perfect little bodies cannot be super or magical unless they look like this. And that is a problem. There are so many examples right now. Channing Tatum says he almost didn't do Magic Mike 3 because of how ill physically and psychologically he got during the filming of the first 2 movies where he was a stripper and had to appear practically naked. In fact, he said, working for 3 months and being miserable, hyper-focused, and restrictive to film the couple of days, within a day of eating and drinking normally, his body would look completely different than the ultra cut, ripped version of himself. But people don't know that. Zac Efron talked about how psychologically ill he got filming Baywatch, that for 6 months afterwards, he had a bad depression after having to abuse diuretics and to radically change how he ate and moved. The New York Times Magazine shared an article on bigorexia, where teenage boys who were getting into lifting begin to see themselves as a little guy, and they cannot see themselves as the size they actually are because they have muscle dysmorphia. And I mean, don't get me started on social media. It is not the cause of ills, but it is the megaphone of ills for our society. And all of these boys are looking at and seeing the millions of likes for guys who might start out skinny and unmuscular, and then the one day they show up painting their sister's house and have a 6-pack, the internet loses its collective mind. This is very compelling, especially at ages where kids are thinking attention that is positive saves me. You know, this is where kids are so sensitive to what will get them attention. And this is one of the most beautiful essays I've ever read by Matt McGorry, a Hollywood actor, My Journey Toward Radical Body Positivity, in which he talks about when he would show up in, I think it was Orange is the New Black, as the security guard who had to take his shirt off. Everybody praised him so much, but he was in his eating disorder then. And when he recovered and allowed his body to actually get healthy, but was no longer super cut and lean, everybody spurned him saying, oh, you know, he's so unhealthy now. He's really lost his edge. Briefly coming back to Jorge, the reason he gets swollen is something called secondary hyperaldosteronism, or pseudo-Bartter syndrome. Our cave person brain thinks I must be dying of dehydration in the desert because of chronic purging. Ideally then, when we next come upon an oasis with salt and water, I'd better have upregulated any hormone I can that will hold on to every molecule of salt and water I take in, because that will protect me through the desert. That's exactly what happens. Our adrenal glands overproduce aldosterone, and we can help this by stopping purging, gently rehydrating, not flooding the body with fluid, and then blocking that aldosterone with an old cheap medication called spironolactone for a couple of weeks until the body gets the message, hey, I'm hydrated, I can stand down. For people with laxative abuse, this is a much harder task. Almost everyone with laxative abuse will get meaningful fluid overload that can even last a year. Jorge needs, he passes out, goes to the hospital. I'm aware of time here. His labs are very abnormal with a low potassium, a high CO2 or bicarbonate, and an elevated kidney function. However, let's just imagine that he can stay outpatient instead, not purge, stay off the scale. We have to support him in understanding that just with simple rehydration, his body can still change pretty quickly. We'll give him potassium, spironolactone, and we'll wait on athletic participation. I'm going to briefly go through my last case because I want you all to know about this. This is a medical diagnosis that may be a game changer. Mira is a 12-year-old who had her first period at age 10. Since she was a toddler, she's had chronic constipation and was a fussy eater who only wanted to eat certain foods. When she gets embarrassed, she flushes deeply over her chest and face. She tends to get random hives on her skin, is very sensitive and easily gets rashes. And once she had an allergic reaction to an unknown trigger, which required an emergency department visit when her throat got tight, but doctors have no idea what's up. When her period started, she felt like something really went wrong. Her health didn't feel right. Every time she ate, her stomach burned and she felt sick. Periods have been so hard on her. She gets terrible mood swings 2 weeks a month and heavy bleeding that causes cramps. She started to lose weight because food felt so yucky after getting her period, and people around her praised her, and then food restrictions started to become more tempting. She does get a drippy nose and a sore throat every time she eats, and she often gets headaches. She feels better during the cooler times of the year and feels sick for a few days after air travel. She doesn't really like being in the sun or heat because she feels so tired from it and her hands and feet get swollen. When she gets hurt, people tell her she's overreacting or she's too sensitive because she has a strong pain response and tends to have pains in her joints. She starts withdrawing from sports and friendships because she's just feeling more tired and unwell. And by age 12, she's been diagnosed with anorexia. This underlying process is called mast cell activation syndrome, or MCAS. Our mast cells are one of our many white blood cells. They hold our histamine and 1,000 other mediators of inflammation. Those should stay inside the cell, but an increasing population of individuals from a younger and younger age are reacting to just common environmental triggers, including food, and they're getting really sick. I take care of a lot of these patients. Interestingly, MCAS is a major driver of POTS, postural orthostatic tachycardia syndrome, especially hyperadrenergic subtype. And those patients cannot get better unless mast cell is addressed. This is an amazing review article, even if pregnancy isn't at all relevant to the patient. And this image comes from that article that essentially all organ systems can be influenced by mast cell. I've been treating it for about 5 years, and I finally feel confident enough in what I'm doing that I've started a blog series, completely free and available. If you go to gaudianiclinic.com, media, blogs, and click back one, there's 4 so far about mast cell and eating disorders. Why should we care? What is this? Diagnosing it, early treatment, more complex treatment. Mast cell is thought to affect 17% of the population. So why don't doctors know about this? Well, it's only been defined in the last 10 years ago, and it's very hard to measure. And we know how doctors are when we can't clearly measure something in a blood test. But I probably have about 40 patients in my panel with this because of the referral bias. Diagnosis involves 2 fundamental schools of thought. Only those with specific measurable blood tests can be diagnosed. I don't follow that one. Or anyone with a bunch of symptoms across organ systems can be started on mast cell treatment, which is very mild. And if they feel better, they probably have some sort of mast cell issue. There are labs that can be done, but they're hard to catch. Those are in the blogs. Treatment 1, 2, and 3 is trigger avoidance. There is no such thing as a truly low histamine diet. And prescribing restrictive eating, of course, is dangerous. But the dietitian has to listen to the patient's lived experience and allow, if they're in a flare because it's finals week, or they just had a breakup, or they just had the COVID vax, maybe gluten gives you terrible symptoms this week. Okay, there's lots of other carbs besides those in gluten. Reducing heat and sun exposure, total avoidance of alcohol and sometimes ibuprofen, reducing exposures to fumes, scents, natural and artificial scents, and stress mitigation. And it sounds orthorexic, but it's real. Avoiding FD&C dyes. You can have all the gummy bears you want. They just have to be organic and naturally dyed. Interestingly, my patients with POTS will try to be being a good little patient and drink their Gatorade through the day. And that's bright yellow or bright blue, and they feel worse and worse. Parents can often start their kids on stuff. If you're like, oh my gosh, I have this, my kid has this, my niece has this. A lot of the starting meds are over the counter. So an H1 blocker is all of the over-the-counter anti-allergy meds. That's twice a day, up to 4 times a day, even if it says 24-hour. An H2 blocker is over-the-counter Pepcid, once or twice a day. There's mast cell stabilizers that are natural, like herbal quercetin. And then we start getting into prescription meds. All of these are available in the blogs. Mira feels hopeful when she's diagnosed with MCAS, that it's no longer all in her head. She requires 4 meds before she feels a lot better, but then feels so much better Bloating, edema, and rashes are gone. Periods aren't fun, but she no longer dreads them. Her mood is better. Her ED is easier to treat, and she rarely gets flares. Last couple resources, there are so many wonderful books and podcasts. Pretty much all the podcasts I've ever had the pleasure of being on are available on our website as well. So if you want to look for specific topics, they are there. These are among my favorite books, including as an alternative to the sort of fairly white, thin focused American girl books for puberty. Sonia Renee Taylor has written this wonderful book called Celebrate Your Body and Its Changes Too, which is much more inclusive. And I just think that Sabrina String's Fearing the Black Body about the racist origins of fat phobia is paradigm shifting. If you haven't seen the poodle science video put out by ASDA, Google it. It's adorable. It is so sweet and really helpful. I think, and I have no financial relationship with it, although I did put a blurb in it, this is the best book for parents and kids about food, How to Raise an Intuitive Eater by Sumner Brooks and Amy Severson. This is my book, Sick Enough. It's available on Amazon. I always finish my lectures with this slide, the title of which is Know When Your Ass is Overwhelmed. Please keep taking care of yourselves as you do this work as a parent and a loved one. It is hard, and you must take care of yourself first, not only because you need the energy, but because your loved one needs to see that you allow yourself to recharge in ways you need, which gives them permission to as well. Thank you, and I am happy to take questions.
I will
Okay,
stop
great.
recording now.
Okay, thank you, Nevin.
Yes, so